Hi, this is Dr. Poole, and this talk will cover liver failure and cirrhosis as part of the John Jackson case. We can divide liver failure into acute and chronic types based on clinical, biochemical, and pathological changes. In acute liver failure, there's the rapid onset of massive hepatocellular destruction, which culminates in liver failure. Whereas in chronic, this is usually an insidious process in which there's progressive hepatocellular damage, usually with periods of regenerative changes in between. Eventually, this leads to cirrhosis and chronic failure. In acute liver failure, the typical pathologic pattern is massive hepatocellular necrosis that's typically associated with encephalopathy and coagulopathy. About 50% of cases in the U.S. are due to ingestion of acetaminophen, but other types of hepatitis and other drugs and toxins can also lead to a similar picture. Pathologically, what we see is confluent areas of hepatocellular necrosis. In this particular slide, the necrosis is found around central veins. So this would be a type of central lobular type of necrosis, or if you look at it from the acinar point of view, this would be involving acinar zone 3 and maybe a little bit of 2. But the important point is that these are confluent areas of necrosis. Let's look at this at a little bit higher magnification, and you can see that the necrotic hepatocytes in the circle are just pale ghost-like remnants of hepatocytes. If you contrast that with the cells in the viable tissue around it, you can, at least at this power, recognize that there's nucleoli and there's some cell structure, whereas in the necrotic area this is all pale and there's no cellular detail at all. This is even a higher magnification view, just contrasting the necrotic hepatocytes at the top of the image, in which there's just cellular debris, hemosiderin pigment, in this brown-gray pigment, and just the ghost remnants of necrotic cellular debris and membranes. In the bottom half of the image, there's viable hepatocytes, and you can easily recognize the cell detail, the nuclei, and so forth. So to summarize, in acute liver failure, we typically see massive hepatocyte necrosis. These are broad confluent zones of hepatocellular necrosis with surrounding islands of regenerating hepatocytes. Grossly, the liver would initially be large because of the edema and influx of inflammatory cells, but then gradually becomes smaller and shrunken as the necrosis becomes extensive and there's extensive loss of cells. There is a second pattern of acute liver failure, which is associated with diffuse microvesicular steatosis, and we covered this general pattern of steatosis in the other lecture associated with this case, and so there's nothing that looks different about it. It's just that the process is diffuse, it's microvesicular type of steatosis, and it's not associated with necrosis per se, but just profound hepatocellular dysfunction resulting in acute failure. We can compare and contrast the consequences of acute liver failure with chronic liver failure, which we'll discuss after this. But initially, one would see jaundice and icterus. This is yellowing of the skin and the sclera of the eyes, respectively. One of the major consequences is hepatic encephalopathy, in which you would see personality changes, intellectual impairment, depressed levels of consciousness, which typically fluctuates, and one of the key signs and symptoms are rigidity and hyperreflexia. Coagulopathy is another important consequence. Remember that the liver is the major site of production for a number of vitamin K and non-vitamin K dependent coagulation factors. So this puts the patient at increased risk for uncontrolled life-threatening bleeding and or intracranial hemorrhage. And then finally, there's hepatorenal syndrome, in which the patient in acute liver failure also goes into acute renal failure. In chronic liver failure, we typically associate that with cirrhosis, which is fibrous scarring of the liver. It's important to note that there's no single cirrhosis, but many types, and also that cirrhosis really just means end-stage scarring of the liver and does not associate with any particular disease on what caused the cirrhosis, so it's an end stage. A couple other caveats are not all cirrhosis leads to chronic liver failure, and I'll mention that a little bit later again, because usually in cirrhosis there's also evidence of regeneration, and sometimes cirrhosis can even regress. Not all end-stage chronic liver failure is also associated with cirrhosis, so similar to acute liver failure is not always associated with massive necrosis. Chronic liver failure can be assessed clinically and then classified accordingly, and this clinical classification generally correlates with the histological features of the degree of scarring and also with the degree of portal hypertension. Cirrhosis is diffusely distributed throughout the liver and is characterized by dense bands of collagenized fibrous scar tissue that surrounds nodules of regenerating hepatocytes. It's also notable that cirrhosis has variable features, both within and between individuals, and even within one individual over time. As I mentioned, the extent of cirrhosis can fluctuate within an individual over time and may even, on occasion, completely regress. Generally, what we see at low power are variably sized nodules that are separated by these bands, which we'll look at higher power on a subsequent slide. But this is what gives the liver its characteristic nodular or cobblestone appearance on external examination. So this is a higher power view, and I want to point out a couple things here. Number one, again, notice the nodules and the separation by these broad fibrous bands. Also note in the center here is an area of ductular reaction, which we commonly see in cirrhosis. So the morphology of cirrhosis can be further characterized by the size of nodules. They can be macronodular or micronodular or a mixture of both. We can also see differences in the pattern of scarring. Sometimes the bands of fibrous tissue run from portal tract to portal tract, or sometimes from portal tract to central veins. And we can also assess the degree of parenchymal collapse, that is, the extent of the loss of viable liver parenchyma, comparing the size and extent of the fibrosis versus the area of regenerating nodules. We typically see ductular reactions increase with the advancing stage of cirrhosis. And again, notably, fibrosis may regress. The scars may be thinner, become more densely compacted, and even fragmented. And when that happens, the regenerating hepatocytes expand and coalesce into larger viable nodules. Death from cirrhosis usually results from progressive hepatic encephalopathy, and patients gradually go into a coma state, massive gastrointestinal bleeding due to either ruptured esophageal varices or diffuse gastrointestinal bleeding from profound coagulopathy, and finally bacterial infections, especially bacterial peritonitis, which carries a high mortality rate. The most important complication of cirrhosis is portal hypertension, And although it does occur in acute liver failure, it's more common in chronic. You can divide portal hypertension into prehepatic, intrahepatic, and posthepatic causes. You can see the table I made in the notes for further details, but in the context of cirrhosis, that's obviously an intrahepatic cause of portal hypertension. The basic cause of portal hypertension is an increase in the resistance to portal flow at the level of the sinusoids because of a variety of different factors, which I listed here. The contraction of the smooth muscle cells and myofibroblasts, that is remember the hepatic stellate cells in the space of DISA, alterations in the sinusoidal endothelial cells, and then finally there's disruption of the arterial and portal circulations due to the extensive alterations in the microarchitecture of the liver from scarring and regenerative nodules. Other causes of or other complications of chronic liver failure include ascites, that is the accumulation of fluid in the peritoneal cavity, portosystemic shunts, which can be seen manifested as hemorrhoids in the anorectal area, caput medusae in the abdominal wall. These are dilated subcutaneous veins, and then esophageal varices, which we discussed a couple cases ago with the esophagus. Because of the chronic congestion from the portal circulation, you can get passive congestion of the spleen or splenomegaly, enlarged spleen. And then you can also see hepatic encephalopathy with chronic liver failure as well. And there's a couple pulmonary syndromes that are also associated with chronic liver failure. One is hepatopulmonary syndrome, in which patients have progressive hypoxia due to ventilation perfusion mismatch. This is actually a fairly common complication seen in up to 30% of patients with cirrhosis and portal hypertension. The pathogenesis is unknown. Similarly, portopulmonary hypertension can be seen. This is pulmonary arterial hypertension that occurs in the setting of cirrhosis and portal hypertension. Again, the pathogenesis of this is also unknown. So what did I learn? Acute liver failure, usually seen with massive hepatocyte necrosis, typically due to toxic injury, most commonly acetaminophen ingestion, but also other forms of hepatitis. And the most common or most important complication is hepatic encephalopathy. We compared and contrasted this with chronic liver failure, which is typically associated with cirrhosis. This is commonly due to a variety of forms of hepatitis, as well as alcohol abuse and other metabolic causes. And the most important complication of chronic liver failure is portal hypertension. So hopefully you're not feeling like this right now, a little bit clueless with the building falling around you. But I hope this talk was educational, and if you have any questions, of course, just email me. Thanks.